Hello, everybody, and welcome to the Fundamentals of Sports Medicine. I'm Max Kammerman, presenting today for elbow anatomy for the clinician. Before we get started, I encourage everybody to follow us on social media, and if you have any suggestions or questions about our videos or other ideas, get at us at email fundamentalsofsm@gmail.com. Just a disclaimer, the Fundamentals of Sports Medicine lecture series should not take the place of an in-person interview with a physician, and of course, FSM has no financial disclosures at this time. Now we're going to get into clinically relevant elbow anatomy. This is going to be elbow anatomy as it pertains to physicians, residents, fellows, and physician's assistants, nurse practitioners, as it would be relevant for athletes and other people with elbow pathology that you might be seeing in the clinic. We're going to get started with the bony anatomy. We're going to work our way from in to out in this lecture. Here on the left image, we can see some of the clinically relevant bony anatomy labeled here for us. Now again, just to make this enormously clear at the start, the elbow is a hinge joint comprised of three bones, the humerus proximally. This articulates with two bones in the forearm. On the lateral side, we have the radius, and this articulates against the capitellum of the humerus. The radial head inserts here. And more medially, we have the trochlea articulating with the ulna. And the three bones again of the humerus, radius, and ulna, articulating against the capitellum and the trochlea. Other relevant anatomical bony sites to know are the lateral epicondyle and medial epicondyle, which serve as the attachments for various tendons and ligaments, which we'll show in a couple of minutes. And then otherwise the coronoid fossa. Moving over here to the right image, we can see a couple of the ligaments, which we'll talk about further in a couple of minutes. But what I want to point out first of all is looking from the medial side, we can see the end of the ulna as it wraps around underneath the humerus. This is with the elbow held at a 90-degree angle. This is the olecranon, with the tip being the olecranon process. Otherwise, we're seeing here the ulnar collateral ligament, or the medial collateral ligament of the elbow, which is involved in an enormous amount of pathology for throwers, particularly pitchers and javelin throwers. And then just lateral to that, we can see the annular ligament, which is the relevant site for nursemaid's elbow, where the radial head detaches and becomes uncovered from the annular ligament. Moving on from this, we're going to have a brief discussion about ossification centers of the elbow. The ossification centers of the elbow are the predictable sites of bony development which occur in the elbow. And this is relevant because A, it's complex, there's 6 ossification centers, and B, because it occurs at a predictable rate and at predictable timing in a child's life, and therefore by knowing the ossification center order, you can understand x-rays better when looking at them. For further discussion of this, check out our x-ray video, by the way. Now I use the Crito mnemonic to help me remember what the ossification centers are in order. And these typically begin at around 1 year of age and appear every 2 years hence. And we'll talk through it right here just briefly. Now again, Crito is C-R-I-T-O-E, and we'll talk about each one individually as we go through. Beginning with the 1 year, here we see the capitellum, which is the C of Crito. 2 to 3 years after that, we see the development of the radial head, the R in Crito. Then we move across to the internal or medial epicondyle, which forms next, usually around 5 years of age. Next, we go to the trochlea, the T of Crito, which we see here. Then we move on to the olecranon, which is not well visualized here on the anterior-posterior view, but which we can see here on the lateral view. Finally, the last ossification center is in the external or lateral epicondyle of the elbow. Again, just to go through it quickly one more time: capitellum, radial head, internal or medial epicondyle, trochlea, olecranon, and finally the external or lateral epicondyle. Just to put a fine point on this, this is not the age, these are not the ages at which the physes will close. So just to drill down on that, the ossification centers will appear in a predictable rate in a child's elbow, but these ossification centers will not fuse together following the same mnemonic. That follows the Tecori mnemonic, T-E-C-O-R-I. Moving on, we're going to look at some muscular attachments to the elbow. I've chosen to represent that here with actually the bones themselves with the muscles just written in as abbreviations so that you can see how the musculature may articulate over the bones. Now, the elbow has three main flexors, though there are other muscles that contribute to it, but if asked ever, the three main flexors of the elbow are the brachialis, which actually is not viewed here, but which originates more superiorly on the humerus and courses down to insert onto the ulna. This is quite a deep muscle in the elbow. The other two muscles are the brachioradialis, the origin of which we see here, and the biceps brachii, which is the classic muscle known to everybody in the forearm, obviously. The biceps also is the main supinator of the forearm, and we can help to, or we're better shown that by noting that the insertion of the biceps brachii is into the radius as opposed to the ulna. This will help to, again, supinate the arm when flexed. Other muscles that do actually contribute are the pronator teres, but otherwise I simply wanted to demonstrate or show the flexor muscles of the elbow. The elbow also has two main extensors: the triceps, which inserts into the olecranon on the posterior aspect of the ulna, and the anconeus, which isn't shown here, but which also doesn't have a tremendous amount of clinical relevance. Moving on from here, we can see now a little bit more of the soft tissue structure of the elbow. Beginning over here on the left image, we see the posterior view of the elbow, and we see the three individual heads of the triceps, the long head, lateral head, and medial head of the triceps, all forming a common tendon inserting into the olecranon again of the ulna. Not well visualized here, but which we can see based on our knowledge from the previous image. And then looking at the anterior view of the elbow and arm, we can see the biceps brachii with its two proximal heads, the long head of the biceps coursing over the humeral head into the superior labrum, and the tendon of the short head as it inserts onto the coracoid process. Now these again form a common tendon, mostly inserting into the radial tuberosity, again the radius as opposed to the ulna, and is a flexor and supinator of the arm, and then of course into the biceps aponeurosis. If we pause here for a moment just to talk clinically why this is relevant, that there are two heads proximally, or two tendons proximally, but only one main one distally. When an athlete or weightlifter tears the tendon of their biceps, they tend to lose less function in their arm if you tear a proximal tendon. Essentially, if you tore the long head, which is the most common tendon to tear, if you tore the long head of your biceps, you would still have the short head to provide a significant amount of flexion and supination to the elbow. you would see a slight decrease in strength, and it may give a different cosmetic appearance, but ultimately you're going to be left with similar function. Now contrast that to a distal biceps rupture where you've lost now the attachment to the radial head. The biceps as the main supinator of the forearm will completely lose that function if you tear the distal biceps tendon. In other words, a proximal tear is not an emergency. A distal tear is an urgent issue that needs to be surgically repaired or the patient will lose function. Finally, moving over here to the right image, we have a cute cartoon of the olecranon bursa, which is the bursa overlying the olecranon of the ulna. This is an area of pathology you'll typically see swelling. It's one of the most common areas to see swelling in the elbow. This can be drained, and again, this is a representation of olecranon bursitis, but it's probably the main bursa that you would want to know in the elbow. Finally, before we finish this lecture, let's take a look at the clinically relevant ligaments a little bit more in depth of the elbow. These images may appear complex, but I think that we can break them down into such a way that they feel pretty manageable. Starting here on the lateral image of the elbow, which again is the radial side of the elbow, the main ligament that you would want to know here is the annular ligament. Again, this is the ligament that wraps around the head of the radius. Now, this is relevant because the annular ligament holds the radial head in place against the capitellum, but especially in children can be or is quite lax. So if people are familiar with nursemaid's elbow, which is a subluxation of the radial head out of the annular ligament is not typically torn in that instance. It's simply the radial head moving out of its anatomical position and then has difficulty reinserting into its correct articulation point. So again, the annular ligament holding the radial head in place. The radial collateral ligament has some clinical relevance, and the lateral ulnar ligament in terms of preventing varus stress to the elbow, but again is not seen frequently as an area of pathology. Moving over to the right side of the image, we see the medial aspect of the elbow, which I've represented here with two separate images. Again, we can see the annular ligament, but what I'd really like to focus on is the UCL, or medial collateral ligament of the elbow. Now here we can see that they are dividing this into three parts, the anterior, posterior, and transverse part. And the medial collateral ligaments prevent valgus stress of the elbow's bowing inwards, and are typically injured in pitchers, again, or people who are involved in overhead throwing sports. Of these three bundles, the main one to know is the anterior bundle, represented here, as it extends from the medial epicondyle into the ulna. Again here. The anterior bundle is the bundle most commonly injured in throwers. Posterior bundle and transverse bundle are far distant to that. The transverse ligament in particular actually only attaches from the ulna back into the ulna and takes no stress in throwing. Again, anterior bundle is the clinically relevant bundle to know of the medial collateral ligament in throwers. Moving on, the last slide that we have today is talking about the nerves and blood supply of the elbow and, of course, into the forearm. We have the brachial artery, first of all, which we can see here on the left, as it courses along the anterior aspect of the humerus and then bifurcates soon after the elbow into the radial and ulnar arteries. This is relevant when looking at the distribution of blood into the hand and can be relevant with some fractures. Supracondylar fractures, for example, can occasionally develop into a Volkmann's contracture, which is involved with damage to the brachial artery. It's beyond the scope of this lecture, though, I believe. What I will talk about for a moment, though, are the three nerves which cross the elbow. Moving from the ulnar to the radial side, we have the ulnar nerve, the median nerve, and the radial nerve. Now, the ulnar nerve, of course, is your funny bone nerve, and you can actually feel that or sublux that occasionally in people if you feel into the medial aspect of your elbow. On the radial side, along the lateral aspect, you can feel the radial nerve. The median nerve, though, is quite deep to these and can't be easily palpated or stimulated. When viewed anatomically, we can see that the median and ulnar nerves are providing the palmar distribution of sensation and muscular contraction to the hand. The ulnar nerve providing most of the intrinsic musculature, actually, but certainly sensation will come from the median and ulnar nerve over the palmar aspect. There are a number of muscles that are relevant to know, and you can see actually our hand lecture for further discussion on the particular innervations of the median and ulnar nerves into the hand and forearm muscles. But one thing that I will emphasize is with the radial nerve, if you take just one point away from the nerve discussion of this lecture, is to remember that the radial nerve acts as the great extensor of the arm. And so almost every muscle that extends in the arm from the triceps moving down is going to come from the radial nerve. Now they have this twisted here where you can actually see an anterior view of the patient as the patient has twisted the hand or pronated the arm. But in the anatomical position, as it is viewed here on the top image, the radial nerve actually courses posteriorly along the entirety of the hand. Again, radial nerve, the great extensor of the arm. This is relevant because when dealing with questions that talk about any extensor muscle, knowing that you are typically going to see the radial nerve involved in that in some way pathologically can be helpful in terms of answering this. That'll do us for clinically relevant elbow anatomy. Again, we are the Fundamentals of Sports Medicine. Check us out on our various forms of social media, and we'll see you next time.